So good morning. Thank you for being here. So we're going to talk a little bit today about the interstitial lung disease associated with scleroderma. So just some disclosures. I am an advisory board member of the Boehringer Ingelheim SENSCIS trial, and also Northwestern was a SENSCIS trial site. So today I hope to outline several things: the why, the where, the who, how, and when of interstitial lung disease. So why is it important? Where in the lung does the lung disease actually occur? Who is at risk? How do we treat it? When should we treat it? And what's new on the horizon in terms of some recent stuff that a lot of you have probably read about or heard about. So why? Why is it important? And I think this one slide sort of covers it all. The changing patterns of mortality in scleroderma, if you look back in the 1970s, it was scleroderma renal crisis. We've now identified the risk factors and have put in place some treatments to avoid that, and as a result, we actually don't see renal crisis very often anymore. So the leading cause of death currently in scleroderma is interstitial lung disease. And between the interstitial lung disease and the pulmonary hypertension, that accounts for about 60% of the mortality associated with scleroderma. So clearly, this is important. So the normal lung extends all the way from the sinuses, well, the normal respiratory tract, I should say, from the sinuses all the way down to the distal airways or the alveoli. And different diseases occur at different points of the respiratory tract. So for instance, asthma up here in the right-hand corner is an airway disease. It's not even really a lung disease. It is associated with hypertrophy or thickening of the mucosal wall and hypersecretion of phlegm. Then emphysema, there's actually a destruction of those air sacs or those alveoli. And in pneumonia, those air sacs or alveoli fill with fluid related to bacterial infection, so more or less they fill with pus. So where does the scleroderma interstitial lung disease occur? So it occurs in the wall of those little air sacs, the alveoli. And let's see, we have a pointer. Whoops, nope, that's wrong. I'm not sure where the pointer's working, so I'll just use this. So here is the air sac here, or the alveolus, and here is the wall. And this is a normal air sac, and you see here the air sacs here and here. The walls between are very, very thin. They're fine membranes. Really, what runs through there is a couple of cells and blood vessels. You want the blood vessel sitting right next to the air sac so it can pick up oxygen from the air sac to carry it through the rest of your body. And so that's sort of a normal air sac. Then if we look at this cartoon, you'll see that here are the alveoli here. Here's another one here. These are the cells that line the alveoli. These are your blood vessels, your capillaries. So they're sitting right next to the wall so they can pick up oxygen. There are a couple of cells, but for the most part, it's a very fine structure. Here it is in disease. And what has happened in this particular picture is all of this green stuff is sort of fibrosis or scar tissue that has been laid down in response sometimes to inflammation, but sometimes in response to nothing, just a pathology. And that displaces the capillaries from the lumen of the alveoli and results in a difficult time for the oxygen to transit from the air sac. And in addition, as you might expect, the lung that looks like this is a lot stiffer. So it's a lot harder to breathe. You have to expend more energy to expand your lungs and move the gas in and out. So both of those things lead to the sensation of shortness of breath. So even if your oxygen levels are normal, you may be short of breath just because there's a fair amount of work to expand that lung. So then what specifically goes wrong in scleroderma? Well, we know it starts with an inflammatory process. I don't see a dot anywhere. So it starts with cells called lymphocytes that migrate into the lung, into that interstitium, and cause this inflammation. And most of our targeted therapy has been towards this phase of the response in the lung, the inflammatory response, targeting those lymphocytes and trying to prevent the lymphocytes from coming into the lung, prevent the lymphocytes from creating local inflammation in the lung. And that's what drugs like Cytoxan and mycophenolate have been targeting, that reaction there. But we also know that the lung then responds, so what happens downstream is that when your lung sees inflammation, it decides it needs to heal something. And so in come these fibroblasts. Now there are resident fibroblasts in the lung, or myofibroblasts, that turn into fibroblasts. And then there are also fibroblasts in the periphery that migrate into the lungs. So you get this influx of these cells that are made to heal. And they lay down what we call collagen, and that collagen is what causes the scar. So this down here then is the secondary reaction to all of the inflammation going on initially. And these are where we're thinking about targeting now. We know that our therapies targeting the immune response have been somewhat limited. We may be able to slow down disease, we may be able to halt disease, we get very little recovery at that point. And so perhaps what we need to do is target the downstream response, or target both of those responses to get a better result than we currently have with our current therapy. So then is the who. What are the risk factors for the development and for the progression of interstitial lung disease? Because not everybody with scleroderma does develop lung disease, and some people who develop it have rather mild and non-progressive disease, and others, their disease continues to progress over time. So some of the risk factors have been identified. Certainly almost about 85% of people with interstitial lung disease do have one of the three markers, but in particular, those who have the SCL70 are at the highest risk of developing significant or progressive interstitial lung disease. Men and African American men are at increased risk, not so much of developing the disease, but having more rapid or more progressive lung disease as well compared to women. And other risk factors that have also been associated with worse outcome includes a diffuse cutaneous skin pattern, short disease duration, so early on in the disease it tends to be more progressive. Your baseline pulmonary function tests are important, but even more important than the baseline is the serial pulmonary function test over time to give us some indication about how the lung disease is progressing. The findings on the high-resolution CAT scan, again, both baseline and follow-up, and also the presence of gastroesophageal reflux disease. What is its role in terms of contributing to progressive lung disease is still uncertain, but we do think that there is a relationship between GERD, the presence of GERD that is uncontrolled, and potentially the progression of lung disease. We say this because that role has been a little bit better defined in other patient populations with fibrosis, specifically the idiopathic form of pulmonary fibrosis. It is yet to be better or well defined in the scleroderma population. So I want to talk a little bit about the when. When do we treat lung disease, and when do we think lung disease is likely to be most active or most progressive? So in the past, we had this historical notion about the lung disease and how it progressed, and this was based on studies, rather large studies, before we really had much in the way of treatment to treat this. So this was watching patients over time that did not have therapy. And what we saw is depicted here is in the first 0 to 2 years was the largest loss of lung function. Between 2 and 4 years, there was less lung function, but it continued. And then after 4 to 5 years, there was really minimal loss of lung function. So we really focused on treating this disease early. The first 3 to 4 years, we said, were really critical times to try to intervene and preserve lung function. And once you had the disease 5 or more years, we worried a lot less. However, this paradigm is shifting a little bit with some more recent data that has looked again at the progression of the scleroderma interstitial lung disease. This is one study. It's a single center study, so we always have to interpret that with some caution. It was a significant 171 patients though, so a reasonably large study. And some of these patients were treated. So again, treatment might have impacted what we see here as opposed to what we see in the historical populations we've looked at. But they took these 171 consecutive patients with scleroderma, and they broke them down into 3 groups. Those who had poor survival, so survival less than 4 years, then patients who had survived from 4 to 8 years, and then patients who were still living after 8 years. So they retrospectively went back and looked at the serial pulmonary function tests in these 3 groups of patients followed at their center. They focused on the forced vital capacity and the diffusion capacity in each of these groups. And so when they looked at the entire cohort put all together, what they saw was exactly what was described earlier in the Steen study out of Pittsburgh, the historical perspective, that the complete cohort did have loss of lung function. So again, this is 0 to 2, 2 to 4, 4 to 6, and 5 to 8. So most of the lung function loss in the first 5 years, and then really little loss after that, so stability going beyond. But that data was a little bit skewed because if you take out those who died within 4 years, so these were the people who had really rapidly progressive interstitial lung disease, that group of patients didn't have data going beyond. So their sort of front-ended data skewed the data set for the entire population. So when you excluded them from analysis and looked at patients, this is the second group from 4 to 8 years, they had pretty much steady loss throughout, even going beyond 5 years. So this group of patients was sort of in the middle range, had lung function loss beyond what we would have anticipated. Then the third group, the long-term survivors, here really had, their lung function loss did slow down over time, but it was still there even at 5 years out. And so we've begun to think a little bit differently about this and tried to decide what this tells us about how we should think about treatment. The diffusion capacity followed the exact same pattern as the forced vital capacity did. So I think this needs to be looked at in a larger multi-center framework, but I think this data is intriguing and certainly has made me think about this disease a little bit differently. Here's just a graphic depiction of the same data, so really sort of pointing out that there are different groups, different phenotypes, as we'll say, of lung disease, some who have chronic progression and some who die rather quickly of the disease because it's rapidly progressive. The thing is, we cannot necessarily identify the folks at the beginning, and that's one of the problems. As I said, this is a retrospective study, so they knew who had died and who hadn't. We don't have great data telling us at the get-go which group somebody is going to fall into. That's been something that we've been looking at and looking for, whether it's a biomarker or an antibody, but we really don't know how to identify the rapid progressors at the get-go. So here in this little schema, at the top we go from healthy lung to scleroderma lung. About the first 4 years was what we used to think in terms of the lung function. Now we're recognizing there's probably a transformation from, the inflammatory process, which probably does burn out, but then there's the second fibrotic damage that comes in. So again, similar to what I showed earlier with the lymphocytes and then the fibroblasts coming in and doing their dirty deeds. Here is the same sort of schema that we start with inflammation. At some point we transition over to fibrosis, and so targeting both groups of cells seems to make sense. Although it still remains that the only option to reverse the disease is really when there's a lot of inflammation going on. So our second drugs would be used more in the fibrotic realm to try to stabilize disease and prevent any further loss of lung function, but it's highly unlikely we'll be able to reverse the fibrosis that's occurred. So it's still very important to treat early. The question is what we should do in terms of treatment beyond the first 4 years. So what does it tell us? It tells us that if there is, and this is sort of what I just said, if there's a long-term loss of lung function, then there is a role to target the fibroblastic response, and that's what the SENSCIS trial was all about. So what was the SENSCIS trial? It looked at a drug called Nintedanib. Nintedanib, also known as OFEV, was a medication approved in December of 2014 in the US for treatment of idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is a little bit different from scleroderma lung disease in that it never had an inflammatory phase. It began with fibroblasts and it ends with fibroblasts. It's a progressive fibrotic disease of unknown cause, hence the idiopathic. So those folks never had an inflammatory situation that brought in the fibroblasts. They'd come there on their own. And that disease in general was associated with about a 5-year life expectancy. Before December of 2014, we really didn't have any drugs that treated that. So when the Nintedanib was approved for that, the data was similar, and I'm going to show a little bit of the data later, similar to what we're finding in patients with scleroderma. It slowed down the progression of disease. It did not stop the disease, but it had a significant decrease in the amount of lung function lost per year. So we thought, well, we should look at this drug in patients with scleroderma since we think they do develop this similar fibrotic process. So the SENSCIS study enrolled 580 patients were randomized and 576 were treated. This was a multi-center trial and run by Boehringer Ingelheim Pharmaceutical. Half of the patients received placebo and half of the patients received the Nintedanib. This was added if you were already on mycophenolate. The mycophenolate was continued. If you were not on mycophenolate, we didn't necessarily start mycophenolate. So about half the population had the Nintedanib added to mycophenolate, the standard of care, and the other half received it without any Nintedanib, without any mycophenolate on board. Patients received the drug for a minimum of 52 weeks. Some patients who were enrolled earlier received medication even beyond that, as other patients who enrolled later continued their 52 weeks. The completion of the study was very high, over 90% in both of those groups. And this is what we found. So this is looking at the forced vital capacity, the loss of forced vital capacity per year in this study. So in the placebo group, about 93 cc's. In the group that received the medication, about 52 cc's. So this is not a huge annual change in lung function loss. It's quite small. But the thing is, it's cumulative over time. So this was 1 year. So you might imagine over 5 years, that's a half a liter, and that becomes much more significant. So over time, this small change probably accumulates into something that is meaningfully important to patients with scleroderma lung disease. And this was statistically significant as well. But you will notice everybody lost lung function, or the average in this study, people lost lung function. So it sort of supports the notion that disease does not really stabilize. This is just a graphic demonstration of the same data. The differences started quite early, within the first 4 weeks, and as time went on, I think the cumulative effect, we saw more of a change in the group at the 52-week period of time. Okay. So now in this graph, what they did is they looked at patients on baseline mycophenolate to see if the two drugs worked better together than not, if we had less of an effect, or what the effect of the combination of the two drugs were. So as I said, about 48% of the patients were on mycophenolates. Most of those were in the US and Canada. And you'll see that the difference in loss of function was less in patients who were taking mycophenolate at baseline, and then more in those who weren't. So about 66%. So the two on the right-hand side, these are the folks who were taking mycophenolate. These are the patients who got placebo. These are the patients who got the Nintedanib. And so 40 versus 66 cc loss, whereas in those who are not taking mycophenolate at baseline, we saw a much larger loss of 119 per year versus 63 per year. Now, the one caveat about this and what we don't know is where along the lines patients were in the course of their disease. So somebody who was in the first year of disease might well have had more of a benefit from the mycophenolate than somebody who was further out, like year 4 or 5. So that we didn't, there are not enough people to look at so many different subsets of patients. So I don't think we have yet a final answer on whether combination therapy is better, if there's a particular period during the course of the disease where combination is better, but at least in this trial it suggested that the combination therapy was probably better than the either drug alone. This is a subset analysis, and I want to point this out because, subset analysis never have a robust population of patients, and so often things don't meet statistical significance because you're looking at just a subset of the entire group. But one thing we did see here was that difference sort of held across a lot of different groups. So your antibody status didn't matter, whether you had diffuse, so statistically it didn't matter. But those who were, so let me show you what this graph means first. Those little dots in the center is the mean, and then the two arms skewing out either side is the sort of the deviation around the mean that whole subset of patients had. So any dot that is to the left of the 0 mark here means that the preference was in favor of the nintedanib versus here would be in favor of placebo. If this little arm doesn't cross the line, it means it's a statistically significant difference compared between placebo and somebody who got the drug. But with these significance data looking here, comparing this dot to this dot. So these were the effect of people who did not have an SCL70 antibody positive, and this is the effect in somebody who did. So you did a little bit better if you had the Scleroderma antibody positive, but it wasn't statistically different. It's just as likely that this difference is by chance. Similarly, diffuse cutaneous disease, limited cutaneous disease, baseline forced vital capacity, or the extent of fibrosis on the CT scan. None of those, whether you had those or didn't have them, didn't seem to make a difference. You still seem to have a response to nintedanib. This is a subgroup analysis that, rather than looking at the clinical features of the disease, looked at the patient population. So they looked at gender, race, where they were enrolled, what country they were enrolled from, and whether they had been on mycophenolate at baseline or not. And what we saw was that age did not matter, gender did not really matter. The one thing, and the reason I have this slide up, I wanted to point out was the African American race. Those folks were the only group where we saw this little dot favor placebo. And that's worrisome. We don't know what that means. And we have to realize there were 18 African Americans in this trial, and that was all. So this is a problem. We definitely need to explore the use of this medication in the African American population. This would suggest that perhaps it's not detrimental, it's detrimental to that specific group of patients. We don't understand why that would be, but we definitely need to explore this further. We can't make too much of it because the subpopulation group is so small, but it did raise a red flag and it needs to be understood. Everywhere else we didn't really see a region, but I'll also point out one more thing. If you look at the patients who enrolled from the Canadian and the US sites versus the patients who enrolled elsewhere in the world, the preservation, the number was a lot smaller in those who were enrolled from the Canada and the US site. We've tried to understand why would our patients have had less of a benefit, and the theory is that perhaps the baseline care is different in these patients. We see our patients in clinic probably a little more frequently than perhaps other countries in the US and Canada, and so it might have just been that the study had a lot of visits. Patients were coming in to seeing us much more frequently, and that perhaps this increase in frequency of visits in countries outside the US and Canada was the difference. But we really don't know why the difference was smaller in patients in the US and Canada, which again makes me wonder about the usefulness of this drug. So I think we have questions that are unanswered about the use of SENSCIS. And I bring this up only because I've already had a lot of my patients reach out to me saying, oh, should I be on this drug? Should I be on this drug? And I think maybe, but I think we need to know a little bit more about it, and we need to go in with our eyes open. And I say that because the next thing we'll look at is side effects of this drug. This drug is difficult to take. As you see, so these are the groups here. So this was placebo. This was patients in the SENSCIS trial, so it's scleroderma, who got Nintedanib. This is the combination of impulsus 1 and 2. This was the study in our patients with idiopathic pulmonary fibrosis. So as you see, diarrhea occurred in 76% of patients in this trial who got the drug. That was higher than even in the idiopathic pulmonary fibrosis groups. And I think that's because gut disease is much more prevalent in our scleroderma population, as Darren already alluded to, than it is in patients with idiopathic pulmonary fibrosis. So 75% of patients with diarrhea. Nausea in a lesser group, but still more than the placebo. Vomiting is the next one down there. No, vomiting, and below vomiting is skin ulcers. So there was really no difference in most of these things. Most of the differences were really related to the nausea, the vomiting, and then some weight loss. So it's not an easy drug to take. It has significant side effects. So if we're going to embark on it, we really want to be sure we're doing it in a way that we have thought about and think you're going to benefit, versus just giving it to everybody. So then also key secondary endpoints that were looked at in this study included the modified Rodnan skin score and the St. George's respiratory quotient, which is a scale telling us how good your breathing felt. Did you feel much less breathless when you took this medication? Neither one of those showed any significant difference. So it didn't seem to have any impact on the skin, and it didn't also make people feel very different at the end of 52 weeks. So, summary of the efficacy then. There was a 44% relative effect on the annual rate of a forced vital capacity decline in the SENSCIS, which was similar to those that were seen in patients with idiopathic pulmonary fibrosis. So we clearly are targeting the fibroblasts, and it's having the same effect on patients with scleroderma as it has on patients with idiopathic pulmonary fibrosis. The findings were consistent among all patient subgroups. I really think they should have had a little caveat in there, with the exception of the African American population that deserves more study. Sensitivity analysis and tipping point analysis support the robust findings. So this is several statistical ways they looked at the data, and every single way they looked at it from a statistical standpoint showed the same outcome, that it was beneficial. There was no impact on the secondary endpoints, and this is considered to be clinically meaningful in scleroderma. So based on this study, the drug has been approved by the FDA about several weeks ago. It is not yet quite available for marketing and use, but I imagine it's going to be very soon. And that, what I mean by that is when your insurance will start covering it if you are deemed a patient for this. It's a very costly drug right now, and so we have to wait until insurance is going to, until it trickles down from FDA approval to insurance coverage. So the other thing I wanted to talk about today is hematopoietic stem cell transplant in scleroderma. This is another therapy that has had a few more recent studies that also, I think, leaves us with more questions than answers. So we now have the results of 2 of the randomized trials done looking at autologous hematopoietic stem cell transplants in patients with scleroderma. So of course these studies were not blinded. You can't really blind whether you got a stem cell transplant or not, but they were randomized. The first one is the first one, the ASTA study, is the European study, and then the SCOT study is the US study. I will point out that SCOT intended to enroll 150 patients, but they cut their enrollment short at 75 simply because it was very, very difficult to get patients enrolled in the study. So the study is not as robust as I think it could have been. But because the results look so similar to the ASTA study, which did achieve its goal enrollment of 150 patients, I think the the results are pretty valid. So the patients were randomized to either get Cytoxan IV monthly for 12 months versus a stem cell transplant. So here the control arm was the Cytoxan. The primary endpoint in the ASTA study was event-free survival. In the Scott study, they had this composite which looked at both death and end-stage organ failures at 56 months. The secondary endpoint was to look more closely at the transplant-related mortality, but also to look at the toxicity, and then also to look at the healthcare-associated quality of life. So this is the ASTIS trial, and what I want to point out here is this is mortality throughout over the years of the ASTIS. These were both long-term trials, so 10-year outcome right now in the ASTIS study. So they looked at mortality, and I think the important thing to spend time looking at on this graph is the first. So this is the people who got stem cell transplant, and you see initially the mortality was higher in that group, and that's because of the transplant-related mortality that in the ASTIS study was about 9%, so a very significant mortality. However, in those who survived the transplant and who you looked at over time, at 10 years, survival was significantly better in those who had had stem cell transplant. So just to quickly touch base, what do we think the transplant is doing? So first of all, we're wiping out your immune system, including those the drivers to the production of the antibodies, the autoimmune response. And then the thought is it's resetting your immune system. So when the immune system comes back, it comes back without that autoimmunity. So it's sort of a reset to your immune system. That is the theory. And we know that over time, some people may relapse. We saw this in the lupus studies when we started using stem cells in lupus, and we're seeing the same thing in the scleroderma, that there is a relapse. Not everybody, but some folks do relapse. So if you survive the transplant, you eventually did better in the long term. But the scary thing is a 9% mortality rate is pretty darn scary. And so, that's a lot to want to undertake if your disease is not necessarily, if you're not going to survive the stem cell transplant. So how do we identify who is at high risk for mortality? And so then the benefit weighs in terms of doing the stem cell. And this is one of the big questions. But anyway, so that's the ASTIS trial. I was going to show you the same analysis, just here in terms of cause of death in ASTIS. So here's the transplant-related mortality, 9. You can't really see this. It's 9%. It's 9%, but most of the deaths in the patients who were transplanted were early deaths due to transplant-related mortality. And then other things, second organ failure between the control group and the transplanted group, we had many more lung, heart, and renal involvement. These are other the later transplant-related deaths. So there were a total of 9 deaths here in the transplant group and 19 in the control group throughout the course of those 10 years. So here, moving on to the Scott trial data, the same thing, except the transplant-related mortality, they actually listed it as 0 because they didn't have any patients in that trial who died right in the peri-transplant period, but over 2 years there was an increase in mortality, and a lot of these were complications of the transplant. Remember, your immune system doesn't constitute immediately, it actually takes a few years. And so the early transplant mortalities were mostly infectious and felt by most to be related to the longer term complications of the stem cell transplant as opposed to the scleroderma side effects. So they didn't see that really early drop. They saw a drop throughout the first 2 years. So here you had about somewhere between year 1 and 2, the lines cross. And then if you looked here at 6 years, you saw improved outcome in those who had been transplanted. So a similar picture as we saw in the European study, that the long-term outcome favored transplant, the short-term outcome, it had higher risk of mortality. Event-free survival was pretty similar as the overall survival in that group. So Oh, and this is just a graphic representation of the same. So I think, is it ready for prime time? I think there are several things that we need to resolve. I think there is a patient population that would benefit from hematopoietic stem cell transplant in terms of global survival and who the upfront risk would be worth taking. I think that group of patients, if we could identify them, is the group who are at high risk for mortality within 4 years. So I already pointed out earlier on one of the earlier slides, we don't know how to identify that group. Some work is being done in this area to try to identify that group. We know that men tend to do worse than women, so that may be one risk factor. We know that people who have rapidly progressive skin disease, so either a high skin disease at the get-go or a skin disease that's rapidly progressing within the first year, is a high-risk group. There should be some evidence that there's organ system involvement, but it should be early organ system involvement so we can salvage and there isn't high risk. If we're looking at somebody who already has established organ system involvement, then there's going to be less to be gained and higher risk. So the timing as well, this is probably something we should embark on as soon as we identified somebody as at high risk for rapidly progressive disease, but they haven't had significant organ damage at that point yet. And then the other thing is the risk of the highest risk of stem cell transplant is the cardiovascular risk, specifically pulmonary hypertension and diastolic heart disease. So a full exploration cardiovascular-wise needs to happen before we undertake a stem cell transplant. Early on, the transplant-associated mortality was quite a bit higher than it is described in the more recent studies, and that was because we didn't understand the risk of patients with pulmonary hypertension undergoing stem cell transplant. So now that we understand that and we have better ways for screening for that, the transplant-related mortality has decreased. None of them have shown zero mortality. I don't think there's a study out there yet that has shown no mortality like the Scott study. So I think we still have to identify the patient population. And so the selection of the patients is really critical. Other things we certainly know is when we look at centers with more experience have many fewer transplant-related deaths. And so it should be done at experienced centers. It has to be an informed decision between the patient and the physician that they understand the risks and the potential benefits. And then there's one other thing I didn't put in there. We still have not refined the best technique. The biggest debate remains whether or not total body irradiation should be done as part of the stem cell transplant procedure. It's not done in the European studies. It has been done in the Scott and the pre-Scott study. There's another trial out there, which was a single center Northwestern trial called ASSIST. We do not do total body irradiation here, and then there's another center at Boston not using the total body irradiation, but most of the other centers in the US are. So we actually need to understand what is the best transplant regimen for folks with scleroderma. And then the last thing is, insurance is not broadly covering this. So again, working with insurance companies to have them understand, who should really be undergoing this and who coverage is appropriate for. So lots of questions around that. And then the last thing I'm just going to touch on, and then we'll open up for questions, is the Scleroderma Lung Study 3, currently enrolling patients. So the Scleroderma Lung Study 3 is looking at the other antifibrotic, also approved in December 2014 for patients with idiopathic pulmonary fibrosis. So that's pirfenidone. Pirfenidone has a much better GI profile than does the Nintedanib. So we're hoping that patients on pirfenidone may have fewer GI side effects than we saw, and we think this is particularly important in our scleroderma patients. In terms of the IPF literature, the slowing down of the loss of the vital cap and diffusion capacity is almost identical between these two drugs. So we anticipate it should give us a similar response, but with fewer GI side effects. On the other hand, it does have a different side effect, which is sun sensitivity. So people develop skin rash on sun-exposed parts of the skin. So we'll have to see how that fares, and our patients already have skin disease. And so that is currently, we're currently enrolling, and this is an add-on again to mycophenolate as the standard of care. You don't have to be on mycophenolate, but So we expect to see the sort of same enrollment. Half the patients may be on mycophenolates and half may not. And we will see what happens with that study. And I think that's it. So open for questions. I think we have a few minutes.